slide-nya nggak bisa muncul untuk video Mars PPNI, IBI, dan Indonesia Rayanya untuk para peserta ya. Jadi hanya bisa muncul filenya saja. Baik, untuk acara selanjutnya itu sambutan dari Ibu Dewi Umu Kulsum. Kepada Ibu Dewi Umu Kulsum, saya persilahkan.
Okay, well, thank you. It's okay about techniques. Okay. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
First of all, let's praise our God Allah Subhanahu wa Ta'ala, the most gracious, the most merciful, the creator and sustainer of the universe, peace be upon Prophet Muhammad SAW, the last messenger of Allah, who has guided human into the right way. Honorable the speakers and instructor from Malaysia, Thailand, Philippines, Indonesia, and also all participants who has joined in this webinar. Good morning, everyone, ladies and gentlemen. It is an awesome and precious chance for me as head of Pusat Studi Kewirausahaan Kesehatan Stikes Jenderal Ahmad Yani Cimahi will be opening in our big event this morning on Saturday 22 of August 2020. Well, ladies and gentlemen, now we will start our session on International Health Webinar by theme Early Detection and Management in Adults, Maternal and Neonatal Emergency for Nurse and Midwife. Without any further ado, we would like to welcome on International Health Webinar the speakers and instructor to transfer of knowledge. And for all participants, hopeful this event give us experience and motivation for us to increase our knowledge, especially in the management of emergency in patient. Now this is the high time, let me to say Bismillahirrahmanirrahim. As the symbol of opening International Health Webinar Pusat Studi Kewirausahaan Kesehatan Stikes Jenderal Ahmad Yani Cimahi 2020, please give a round of applause. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you for Mrs. Dewi Umu Kulsum. Then after that is Mrs. Rahmani Sakina. For the speech, time is your Mrs. Rahmani Sakina.
Yeah, thank you so much for Mrs. Ingrid. How are you, everybody? Assalamualaikum warahmatullahi wabarakatuh. I hope everybody is healthy because it's the most important. MashaAllah, is so thankful to everybody that can come in this Zoom webinar. Let me introduce myself. My name is Rahmani Sakina. It is a wonderful and precious chance for me to open this seminar and welcome all of you here. In this beautiful moment, I would like also welcome to our speaker, Dr. Inayah S.Kep.MB from Madani Founder, Mrs. Dewi Umu Kulsum, Nurse M.Kep Specialist Perawatan Anak from Jenderal Ahmad Yani, and also the speakers, Professor Dr. Abdul Ali Dr. Abdul Ali, Head Emergency Medicine of Malaysia, Mrs. Prapporm Langputeh, PhD, Director of the Project Faculty of Nursing, Fatoni, Sir Den Regie, Bautista, M.N.RN, Comprehensive Emergency Nursing, Mrs. Diyah Tepi, M.Kep, Practitioner and Midwifery, Sir Welas Riyanto S.Kep.MB, Specialist Keperawatan Medical Bedah from Emergency Department of Fatmawati Hospital, and also all the audience, welcome. First of all, let's pray and thanks to Allah Subhanahu wa Ta'ala who has been giving us mercies and blessings so we can attend this seminar without any obstacles, and everybody is healthy here now. Secondly, may peace and salutation always been given to our Prophet Muhammad Sallallahu Alaihi Wasallam, who has been guiding us from the darkness to the brightness. We are the nurse and midwife has the main role to give the best quality of patient care, because we are the one who take care of the patient for 24 hours. So we are the one maybe knows the first time when the patient condition is worse.
Yang untuk
So
multiple
we
itu gimana?
topic the seminar, National Health Webinar, Early Detection Management in Adult Maternity Neonatal Emergency for Nurse and Midwife. Last but not least, this seminar can be held because of the PPNI and the Madani and also all the committee and all the audience. So thank you so much. Finally, of my heart, I do apologize if any mistake during this seminar because this is our first seminar. But I hope everybody enjoy. So thank you. Applause for all of you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you for Mrs. Rahmani Sakina for the speech. Okay, now we will start from the webinar, right? For the first presentation by Mr. Assoc Prof. Dr. Abdul Ali bin Raja from Malaysia, with the title is Comprehensive Emergency Neonatal and Obstetric Care Management. So please, Mr. Time is your. Mr. Ali.
Yes. Yeah.
Yes, Mr. Ali, time is yours.
Yes.
So please you, did you know about Prof. Ali? Yeah, okay, so his time is your, Prof.
Okay, thank you very much.
Oh, I'm so
Assalamualaikum.
sorry. The time is just 30 minutes, right? It's done more. It's
You
not
are
more
reminding
than
me.
30
Okay.
minutes, right? Okay, Prof?
Yeah. Hopefully. Hopefully.
Yes.
I'll try.
Yes.
Alhamdulillah. Yeah. Assalamualaikum.
Waalaikumsalam.
Selamat sejahtera. Assalamualaikum warahmatullahi wabarakatuh. Yeah.
Waalaikumsalam.
To start off, in the first place, we render thanks to Allah Ta'ala for the very excellence of the order of the creation and the abundance of its benefits. His mercies are upon all the prophets, yeah, and we pray for the best during these very difficult times. Yeah. So welcome to everybody. Yeah, we are in the path of learning as much as we can. In this knowledge, we know, yeah, many of us are from far. I'm from Kuala Lumpur, yeah, and we wish, yeah, that we continuous learning. This is the 8th course. And I calculate this is the 8th course that we are here. Yeah, I would like to thank the organizers, Madani Health Training Center. Dr. Inaya is here, yeah, along with Nina, yeah, Didin, yeah. Thank you so very much for the invitation. Yeah, alhamdulillah. Yeah, Dr. Inaya is looking younger actually. Yeah. Alhamdulillah. So yeah, what is this about? Yeah, we are living, yeah, in this era, this new era. Yeah, COVID-19. Yeah, day by day we are learning more and more knowledge about this new disease. Yeah, so what I'm going to set the introduction to the floor about the problem that we face right now. Yeah, as well as how do we manage? Is there any difference in the management that we do? Yeah, so my topic is on this acute management. Yeah, but before we understand, go on to acute management, we need to understand, yeah, what is happening. So my resources are continuous. Every day we are learning new things. Every moment we have now continuously the resources change, and I'm going to talk about it step by step, yeah, as we go along. So the objective of our talk today. Number one is to briefly go into a pathophysiology and clinical features, any issues and updates, and certain important guidelines. Remember, these guidelines are not fixed. We are learning. But ultimately, there are three major issues. That is, we want to slow down the transmission, we want to reduce mortality, and we want to maintain this low. Remember, COVID-19 is not going to go away. COVID-19 is not going to go away. It is a new disease that has spread all over the world. There are 213 countries, territories. 23 million has been infected. 15 million has recovered, but we are closing to almost 1 million deaths. Right now, as of this morning, we have reached 800,000 people have died for the past 3 months. Because of this disease. Therefore, this new disease has become a pandemic since the March of 12. It is a pandemic. It is a new disease. But this virus, we call this coronavirus 19, coronavirus has been there before. SARS, from China, MERS from Saudi Arabia again, and this new disease is, what is special about this? Unlike SARS and MERS, this is very highly contagious, and that's a problem. Because it's highly contagious, these are the studies, studies of it, there are 3.1% fatality rate, and that's no good. There's 3.1% fatality rate, and many of these become very sick. Many of these become very sick, and they need intense support. And so we are going to look into these issues. If we describe the brief pathophysiology, we know that this is a RNA threat virus. It's an RNA threat virus. We know the structure. We think that it came from the bats, Kelawa dulu, and then slowly it went into the pangolins, the host, and then it spread to humans. And then from the humans, we are spreading so very fast. We are spreading so very fast. And this is what we are going to talk about. So the transmission, is by droplets, aerosol, direct contact, and fomites. And we'll discuss about it. What is this big issue? Influenza pun ada banyak yang flu virus, various flu viruses, but what is it so special about this? We are going to talk about it. And of course, as soon as the virus comes into the body, the RNA gets released, and it breaks down the host cell and creates new viruses, new coronavirus, and it starts spreading. Very simple. It's a very simple structure, very simply comes into the body, breaks down the body and the cells, and immediately it spreads. And we are going to look into it. And this is a problem, because unlike the other diseases, they've got a huge endothelial damage. Pathophysiology here, there's a huge endothelial damage, and this is, it affects the white cell, it affects the lungs, it affects the circulation. It forms small microclots. And that will affect the heart, affect the kidneys, and the very vital organs. And more importantly, in the lung, and this is a problem. In the lung, when it moves into the lungs, and there is a massive, what do you call that, a cytokine storm. And this is what you need to know. This cytokine storm, it breaks down the endothelial cell, the epithelials, and a huge amount of products, huge amount of secretions, and we almost suffocate Apa kita kata kita it gets blocked by this, alveoli gets blocked by this, and we get this whole of this problem: fever, cough, dry cough. Later you get blood in the sputum, severe myalgia. People who recovered, they are so much in pain, and of course they have got shortness of breath, cough, and they go into shock. And this is what we are going to consider. What is this? So we have divided, so far for the past 4 bulan ni, 4-5 bulan ni, we have divided into, mild cases, most common symptoms, serious symptoms, critical symptoms. So you've got common symptoms: fever, cough, fatigue, anorexia, a little bit of sputum. But the sputum is blood-stained. And severe myalgia. Serious symptoms, that's when it becomes a problem, because when you have shortness of breath, and then of course some chest pain, and then then because it affects the respiratory system, difficult to speak. And then critical is when pneumonia sets in, hypoxia sets in, and then you're going to get septic shock. And then acute kidney failure and lots of multi-organ problems. And the aches, body aches, all these semua ada lah. Tapi this is what that kills the patient. Goes on to multi-organ failure. If you see, the various published, this pure published, you can see that, you see, majority of these patients, had respiratory cause of cardiac arrest. You see that? They don't get a heart attack. They don't get a heart attack. It is a multi-organ failure, respiratory failure. They get arrhythmias. You get a little bit of short arrhythmia, pum, they go into asystole. That's why in your resuscitation, you've got to be careful. It is not a standard kind of resuscitation. So they can go into VF straight away. But the problem is the body is already sick. It's so sick. So another case, you can see that they all die of hypoxemia, hypotension, myocardial ischemia. Itu yang damages the tissues. So in Malaysia, we have divided into 4 stages. With 4 stages, we have close to about 9,000 cases now. We have got 124, about 30 deaths. We have got 1.39%. Very low. Compared to other countries, where they've got 3%, 4%, kita punya hanya 1.39%. Why? Because we detect early. Every patient, yang kita try to this thing, we stage it. Stage 1, stage 2, stage 3. This is where we admit the patients. Early detection and management is afforded. And this is what we do. We give ventilatory support, and non-voluntary respiratory support. We start on antivirals, antibiotics, immunomodulatory treatment, prophylactic, management of the thromboembolism, the fine clots, hemodynamic support, nutritional support. This you can get in the website. All this you can get in the website. So you type the Ministry of Health guidelines for COVID-19, dah banyak dah keluar dah. So this is something you can get it in the website. It's a standard management. Standard management of fluid management, antibiotics. Antibiotics is not for the virus, for the super added infection. Vasopressors, we use noradrenaline. Enteral feeding, we start. Make sure patient's sugar is stabilized. Sedate, gently sedate. And remember, the most important thing is this: hypoxia, management of hypoxia and this multi-organ failure. And this is what we are very much concerned of. And we are very concerned of the elderly patients, the older patients who have got a comorbid problem, respiratory problem, hypertension, heart disease, cancer, previous stroke, previous diabetes, previous chronic disease. These people are very, very prone to very severe infection, multi-organ failure, and these are the patients who normally die. And so in children, what about in children? In children, you see that they don't get a cytokine storm like in adults. What they have is like Kawasaki disease. They have got, this is a new disease in children. There's a multi-system inflammatory syndrome. Not all get it. Only a few children get it. But they get persistent fever. We are still trying to understand in children. Still, every day, if you go to these pediatric annals, every day there are new things coming up. We are trying to understand what really happens to the cell in the children. And so while having this, what are the issues? What are the updates? What are the issues berkenaan dengan COVID ini? So this is it. Why is it a pandemic? Why are we so this thing is because of yang ni. Manusia kita ni dah biasa dengan kebiasaan. See that? Kita dah biasa dengan kebiasaan. What is that? And this is what it is. When we speak, you see that, in measles normal, when we speak, we produce drops in the saliva. And this saliva has got these viruses. And continuously we throw these viruses out. But the problem is, this virus is dangerous compared to Ebola, measles, or whatever, it doesn't matter. But this kills, this maims, this causes mortality. This is a difference. Along with that, we cough, we sneeze. And we do that, more sprays are put into the air. When more sprays are put into the air, this is a problem. This is the problem that we need to sort out. The close contact. Itulah masalahnya. Our major problem is we need to avoid close contact with COVID-19 patients. That's why this isolation is so very important. Remember, 1 meter distance. If you have with a COVID neighbor, if you are 1 minute, and if you are within for more than 15 minutes, sure you get it. Sure you get it. That is scientifically been proven. And that's where you have got to, we are very concerned. We need to isolate. We need to reduce the direct contact. We need to reduce the secretions. We need to reduce a contaminated area. So when we work together, we need to rearrange our workstation. We need to have PPEs. We need to protect ourselves. And we need, we shouldn't be in close environment. Because we are living like saudara mara kita dan sahabat-sahabat kita, itu akan kena dikurangkan. And this is the major problem. The problem is, many at the same time. Because they jangkit tu cepat, very contagious, many people fall sick. When many people fall sick, we have got only limited resources. And because it becomes overwhelmed, disruption, and there's an increased mortality and morbidity. See, for normal healthcare system, is this a level? Suddenly you've got a huge amount of people with the respiratory problems. Our ventilator, dalam each hospital, we might have 20 ventilators. But kalau dah rada 100 pesakit, apa kita nak buat? Macam mana cara kita nak buat? That is the issue. So we need to flatten this curve, and this is our challenge. Every of us have got this challenge. Right down from our president, our Kokowi, hospitals, patients, security, and the equipments tak cukup untuk challenge this thing there, and we die lagi susah lagi. Yeah, and so this whole change of our society becomes a major issue. Children they've got a different psyche because they cannot talk, they cannot run around, and they worry, anxiety, fear. That means these children will change, their psychology akan berubah. Yeah, and this is what our concern is. Yeah, there are 6 types. We need to wash our hands constantly. Suka tak suka, we need to wash our hands because it will go to our mouth. We suka tak suka, we have got to avoid close contact. Suka tak suka, you have to encourage our relative to stay inside. Suka tak suka, we shouldn't cough and sneeze. Kalau kita cough and sneeze, cover our face. We must wear face mask. We must clean and disinfect. Yeah, and we need to look ourselves because it is not easy. Kalau kita nak confirm, kita kena buat PCR test, not any other test. We need to do PCR test and it must be done like this. Yeah, it needs to be done through the nose, not through the mouth. Yeah, so technically it is difficult. And number 3, we need to flatten curve 2. And this is what we are trying to do. Resuscitation or all that, yeah, we are trying to flatten this curve so that, yeah, more resources can be available for the really sick patients. Yeah, and while doing this, yeah, we need to be very careful. How do you do that? How are you going to do that? Remember, yeah, in a cardiac arrest care situation, whether it's adult, child, or neonate, yeah, there are lots of variables. Yeah, banyak, really, gender, location of the arrest, mana dia arrest, yeah, siapa ada dekat dia, yeah, whether there's an AED, whether it's a EMS, response time, treatment availability, dalam biasa pun susah. Dalam keadaan ni lagi susahnya. Yeah, and this is where it is. But problem, the main issue is macam mana kita rawat tu doesn't change. Macam mana kita rawat tu doesn't change. What is this thing is the technique. Macam mana kita jaga. So all this way cannot do. We need to ventilate the patient, but you cannot do this. What we have been trained to do, what we have been saying, kita boleh buat. What we are trained to do like this, gigi sakit, terus pergi ke dressing, buat macam ni, tak boleh. Patient collapse, do like this, tak boleh. Patient collapse, the whole team manage a patient, tak boleh. 5 minutes.
Yes.
Yeah. So so you see now we have got to change. We've got to change the way because we don't want you to become sick. Yeah, and this is the key problem. The frontliners are so very important. The frontliners have got to wear the PPE. Distancing, social distancing is important. You cannot do look, listen, feel. You cannot use pocket mask, no mouth to mouth. Even if you use BBN, it must be very short period of time. Intubate the patient early. You can do defibrillation, yeah, but the resuscitation must be with PPE, yeah, and the standards are the same. Whether you use BLS, pediatric LS, neonatal LS, or ACLS, they all the same. They don't change. Yeah, and then of course, yeah, this, yeah, Ilko says, yeah, if you have any difficulty, just do chest compression. Yeah, do only compression alone. If you are going to resuscitate, you must resuscitate with PPE. Dah, maktub dah. If you don't have PPE, do not, you do not have to resuscitate. Just do chest compression, put a plastic bag, put a face mask, yeah, on the patient. Face mask is more ideal. Yeah, do not open the airways. Do not, yeah, just apply a plastic sheet, just clear plastic you can put on the face. Yeah, and then of course wash your hands, mandi better, bathe yourself after the resuscitation. Yes, so screening is important, and this is a standard. Yeah, so this is the standard that we recognize. Yeah, and then of course in health personnel, remember you must protect yourself. Yeah, you must constantly protect yourself, and all the standards that you have been taught, we continue the same. Yeah, safety precautions, yeah, you follow the same chain of survival. Yeah, the management itself, yeah, is Yeah, same. But how do you know a patient is going to become ill? This is one method. Yeah, if you type in the Google, you see a national early warning score, you'll get it. You can use this. Yeah. Plus to that, this is important. This is an excellent equipment. Harganya RM35 saja. Yeah, so this is something that tells you whether the patient has got adequate oxygen. Because remember, the patient might look all right, but he is hypoxic. We call that happy hypoxia. So it's important that you know these values. Yeah, remember, yeah, the normal is more than 97%. Yeah, if it is 95% and below, there's something wrong. You must go to the hospital. So this is what we advise many patients. Kalau COVID, simpan ni di rumah, on and off, check with this. Yeah, and this will guide you through this various thing. So so management of this follows the advanced life support, whichever it is, whatever basic life support, advanced life support, you do not listen to the breath, you don't go near, protect yourself, and organize itself logistically, yang ni macam dulu, dulu yang ni, to say, but now, you got your, what you have now, is this. Don't PPE and don't PPE, wear the PPE and intubate early and manage appropriately. This is what you need to do. Yeah, and then of course these slides are there. You can go over through. You see that this is important. Yeah, PPE is important. Yeah, and of course intubate the early. If you want to resuscitate a long time, use these machines. Yeah, and then this is some technique which we use now, prone position nursing. Yeah, so you need to know how to place, and this slide tells you, about how to place the AED, how to place the pads and all that. Yeah, in children, they do not go into that sick, but if they do, we have got to have general management about them. Yeah, standard. Yeah, appearance, work, breathing, circulation, the whole thing standard. Most important is the hypoxia. Yeah, so ACRS standards, we follow standard. Newborn, remember this, newborn neonatal care, follow the standard guidelines. Remember, if the mother is asymptomatic, she might be infected. So we kita kena jaga. Remember, and also, always, have 2 meter distance. This is important. Yeah. Okay. We're going to finish. We are going to finish. Yes. So newborns. You've got to. Remember. There is. The risk of vertical transmission is very less. So premature. They sometimes will go to premature labor. Kena jaga, but follow the standards. So ethical framework. Remember, if you always talk with the relatives. Tell them this is the state. If the patient were to collapse, we might not resuscitate. You can tell them now, because this is standard practice now already. Then of course, virus. This vaccine and the virus. Remember this virus, now latest 2-3 days ago, we have got a new virus. It just changed its structure. That way there, it will go on, but we will develop by January, we will have the vaccine. But this disease will constantly be there. So follow the best practices, that is advertised. Go to these websites, learn this. Alhamdulillah. So thank you for everything that we have been given to us by Allah Ta'ala for now, as well as for everything that we will get. But the most important thing, remember, what we do, we are all in the business of saving lives. And of course, we all save mankind. Allah Ta'ala. Okay, thank you very much.
Was for Prof. Ali. Yes, thank you for your explanation. So I will, can you one chance for the question? Ada yang ingin bertanya? Hanya satu penanya saja. Ada? Jika tidak, kita akan melanjutkan ke pembicara yang kedua.
Okay. Thank you so much. You can email me if there's any say. You can personally email me, and then we can discuss further. Thank you, Didi.
You're welcome, Prof. Ali. Baik, jika tidak ada yang ingin ditanyakan dengan Prof. Ali, nanti bisa email saja ya. Karena Prof. Ali sudah memberikan emailnya waktu itu ya, Prof. Sudah memberikan emailnya apa belum, Prof?
Ada di slide nih.
Iya, nanti nanti oleh Prof. Ali diberikan emailnya. Baik, thank you so much for Mr. Ali for the time explain for your subject, and then after that, okay, this one is second presentation. And then second presentation is presented by Mrs. Prapporm Langputeh, PhD from Thailand, with the title Pra and Intra-Hospital Basic Trauma for Nurse and Midwife. So please, Mrs. Prapporm, time is yours.
Yes. I'll try to
Ready, Mrs.?
Okay. Yes. You see my slides?
Yes.
Okay. Shall we start? Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, the organizers, and also the speakers, and especially the audience who attend this Zoom seminar. I'm Prapporm Langputeh from the project of Faculty of Nursing, Fatoni University in Southern Thailand. Alhamdulillah, thanks so much for inviting me to join this seminar as a speaker on the topic role of nurses in handling emergency obstetrics and newborn care. So I think maybe twice already I joined this seminar and also in the same topic, but actually it's always in update and also always trendy because of there is something new every time in medical. Yes?
The time is just 30 minutes.
30 minutes?
Yes, just 30 minutes, not more, right?
Okay, let's try. Okay, next. This is the guideline of my presentation, but maybe I go faster on the role of nurses in midwife in emergency care for the mother and newborn, and also the functional emergency unit care. And let's see, this is the general of facility that we should have in the hospital while we are the maternity unit care. This also should be a service available 24 hours and 7 days. And the member, the staff member should be a skilled provider, and also there is a referral system and reliable electricity and water supply. This is just the general in any hospital. But why we look at when we look at the maternity care, mostly we focus on ANC and postpartum care, right? Is to prevent the complication or also doing the early detection of the mother and the baby. And also the mother also, should be taught to recognize the problem and to be prepared to seek help immediately. This is very important. And in the setting or our unit, we should have monitoring and management of the labor by using pathograph and infection prevention measure, as well as active management of the third stage of labor. And routine care for the mother also to prevent the prolonged labor by doing active management of the third state of labor, right? While in the postpartum care, the mother is taught healthy self-care and also care for her newborn, including early detection of the problem, and as well as the family planning also integrated in normal NC, labor, or even postpartum care. For the newborn, most of the midwife or the nurses should protect of their temperature, like to prevent hypothermia, right? And it immediately give her or him or he or she exclusive bed feeding and preventing of the infection. So this is the concept of emergency obstetric and newborn care. Is actually introduced by the WHO, UNICEF, and UNFPA in 1997, long time ago, huh? And then it's actually to the intervention to provide the pregnant woman and the newborn who experience the fetal complication, right? There is two types of the emergency care. The first one is the basic emergency care in maternal and newborn. It is to reduce maternal and neonatal death, and also this care is to provide with skilled staff in the healthcare center. So the basic emergency case include the administering of antibiotic, uterotonic drug, and also manual removal of the placenta, and assisted with vaginal delivery and preferably by vacuum extraction. This and also doing the basic neonatal resuscitate care. And for the comprehensive ones, is typically delivered in the hospital, includes all basic function plus capability of performing cesarean section and safe but transfusion, and also provision of care to sick and low birth weight newborn, including resuscitation. So now we come to the role of nurses and midwife in emergency obstetric and newborn care. So the first thing is that we should do the rapid assessment and management. When the mother comes to our units, so we assess the general condition of the woman immediately on arrival, quickly identify an emergency or prepare to rapidly treat or refer. You should know the competence of your hospital, the level of your hospital, and the capacity or any facility of your units. First of all, we check or assess on is she in the shock, or is there any vaginal bleeding, or are there any convulsion, or is she unconscious, or is there any severe abdominal pain, dangerous fever, or having difficulty breathing, or the last one is there any danger signs present. So when the mother has the shock, so what should we do? Put the patient in her left side on her leg elevated and insert an IV line and start fluid, right, rapidly, and also cover with the blanket for warmth and initiate hospital transfer in case if she admit or come to the primary care unit. Stay or go should be assessed if it depends on the facility of your unit, or also if you already tertiary hospital, so all everything is there, right? You can take care of her immediately. So we assess what happened with her. Is any bleeding, mostly caused by uterine atony. The most common cause of postpartum hemorrhage is uterine atony. So how to prevent the postpartum hemorrhage? Mostly we give her the active management of the third state of labor, and then which includes the administration of uterotonic as soon as the baby is born, and deliver the placenta via control contraction. This is should be done by the experienced midwife, right? And also the uterine massage after the placenta is delivered. How to perform the control contraction? It must be gentle and only during the contraction, and always stabilize the uterus, and only pull the cord downward, steady direction. Stop if the uterus move downward, or if the cord is tearing, or if the pulling hurts the mother. So this is I would say that it's a bit serious performing action of the nurses, but should be more experience on that, because of they need high skill or advanced skill of the nurses. And also you can do the massage of the uterus and check the uterine tone and massage if soft, and also to contract the uterus and feel is it hard or small already, like the coconut, something like that. And also the competence of the nurses or the midwife who stay in the labor room should have the experience, or should have the should know how to do the BLS, right, or ACLS. And this is the drug or the medication should available in the labor room, right? This is oxytocin, how many units we use, and also the misoprostol. Mostly the doctor order after severe post hemorrhage, something like that. And this one, agometrine, also should be available, and should not use if the with the patient in eclampsia or pre-eclampsia or hypertension, or retain placenta as well. And then if the bleeding heavily before placenta separate, mostly sometimes if the mother still conscious, and we also give the baby forward feed and empty bladder, and if feel the abdomen or for the second baby, sometimes the baby there is twins there, so we need to check everything if the placenta is not separated. And then the sign of placenta separation, this is just the normal thing. Maybe I can go faster on that. I think all midwives already know what's kind of sign of the separation. And then sometimes if the mother need to do the removal of placenta, the nurses should know how to take care of the mother after doing the placental removal, manual removal of placenta. Mostly we administer the oxytocin and massage the baby. Sometimes the doctor order antibiotic, right? We should admin. Is there any irritate or any serious problem after administered the antibiotic, right? And then next one is the hypertensive disorder in pregnancy. We should identify what kind of hypertension she is. And then mostly the problem with the mother is the pre-eclampsia, severe pre-eclampsia, or even eclampsia. It's always happen after 20 weeks, and also come with the danger signs like nausea, vomiting, epigastric pain, HH, visual change, right upper quadrant pain, something like that. And this is the classification of the eclampsia or pre-eclampsia. So you can use this slides to understand the classification of the eclampsia, pre-eclampsia. So mostly the diastolic of the mother is higher than 110. And then the treatment of the mostly the doctor always to prevent the convulsion, serious to pay attention about that. During the convulsion, we should try to prevent fall and injury of the mother, and also keep in the left side position, and to observe closely while administer the magnesium sulfate. So after convulsion, the mother should also continue the IV infusion and also keep the mother on the left side and continue with the magnesium sulfate as well. For this kind of medicine, the magnesium sulfate, mostly the doctor give for the mother with severe preeclampsia or preeclampsia. The side effect of it is warmth during the injection and also fasting, thirst and headache, nausea and vomiting. So this is sometime we, sorry, let's go, sorry. Okay, where is the slide? Okay, here. So why administer the magnesium sulfate? You never give 50% solution magnesium sulfate through IV, okay? And that dose should be stopped if the knee-jerk reflex is absent and also urine output less than 160 in 4 hours and respiratory rate less than 16 breaths per minute, okay? And then monitoring closely on the vital sign, urine output, respiratory rate, and also deep tendon reflex. Hold next dose if until the sign come to normal, okay? And if it's a rage, you should the calcium gluconate should be available on the unit, always available, okay? Because if we have the respiratory arrest by using magnesium sulfate, this is the antidote to assist the mother, okay? Next one is the infection in the mother. So we always use the standard precaution in every health facility and also the clean birth practice in health facility and also clean delivery kits, okay? And then let's see, is there any cause of the infection? There is so many causes as well. So try to prevent, and mostly some doctor order the antibiotic if there is the sign of infection on the mother. So I've go faster on that. And then the other one is the prolonged labor. So most is very serious condition of the mother as well in the case of like twins, big babies or something like that. So the Prapporm is introduced by the WHO long time ago, and many hospitals use this kind of Prapporm. So I think you already familiar with this. And then for the newborn, mostly the newborn in our NICU care is infected with severe infection, death with severe infection, or preterm birth and complication as asphyxia. So what should we do is the nurse or the midwife who's working in the labor room should have the skills on newborn resuscitation. So this is the guideline of newborn resuscitation. This is the updated one and very in detail. So we can go faster on this slide since I have only 15 minutes and maybe it's 5 minutes, right, left. And also this is the transportation and referral system, which every hospital should have this, because if you are not tertiary care, mostly we refer if there is any severe condition of the mother or even the baby. So this is the referral system that we should prepare to expand before we send the patient to the next level of setting of or the hospital. We should explain the diagnosis and the condition of the mother or the baby, and describe care provide, including the medication while we are taking care of them, and estimate the time on arrival, and also send a referral letter with the patient. All the treatment or all the care we have been done should be written down completely before sending the patient. And also during accompanied by the provider and the companion, together while we send them to other hospital to and also monitor the newborn to ensure the first dose of antibiotic is given, because sometimes there is a problem with infection during we are taking care of the baby and the mother and maintain the IV fluids. Okay, next one, if there is shock by maybe sometimes the abruptio placenta or postpartum hemorrhage, we also should prepare the blood transfusion for the mother. This is all the care or the treatment or nursing care of the mother who having blood transfusion. Before giving the transfusion and during the transfusion and after the transfusion, this is we should be prepared and for the mother. And this is how to prepare the patient or the mother for the surgical treatment. If there is any severe problem like the bleeding or retained placenta and cannot remove the placenta, sometimes we send them to the operation room or operation theater. So the mother should be open the IV line and retain the catheter, check the vital sign, prepare the blood transfusion, inform the relatives and consent from, and communicate with staff and nurse, uterine massage, bimanual confession, something like that. The medication or any document should be prepared and sent to them. And for the low birth weight baby, the premature baby, so how to do to stable the low birth weight or the premature baby, mostly to prevent the hypotension, hypothermia of the baby, right? We can do the kangaroo care or early and exclusive breastfeeding feeding on demand, and also warm the baby and protection from the infection. This is the normal care of the baby with the low birth weight. Hypothermia and hypoglycemia and poor growth of the baby. Okay, and then care of the low birth weight and premature newborn, just only focus on the thermal protection and hygiene care to clean and dry. This is the few last the functional emergency obstetric and newborn care service require the supportive require supportive health system, supportive policy, and effective referral system, community education and mobilization. And also the facility should have space and privacy. Space and area of should be private, and regular supply of equipment, supply and drugs. Okay, I go faster. I think the last one. Okay, the human capacity should be insufficient in the number and 24 hours a day and 7 days a week, and trained to competence to pre-service and in-service training. And also human capacity should have legally support in performing this procedure. I mean, all the procedure should be done in the ER or labor room, and should have the job description of each individual, like staff nurse or the in-charge nurse, something like that. And strengthen with ongoing day-to-day management and supportive supervision adequate. And then, yeah, it's the last slide already. Okay, I think within a short time, I can give you some overview of emergency obstetric and newborn care, and how to perform it well and take care of the mother and the baby to be happy mother and happy baby. Okay, is there any question on my presentation?
Okay, thank you so much, Mrs. Prapporm Langputeh. So just one chance of the one question. Just one question. Ada yang mau bertanya? Hanya satu penanya. Okay, I think no, Mrs. because time is limit, right? Okay.
Okay, thank
Yes,
you.
thank you so much, Mrs. Prapporm Langputeh. So give applause. Right. Okay, thank you so much, Mrs. Prapporm. So that is with the
You're
presentation
welcome.
is about comprehensive emergency obstetric and newborn care and management from Mrs. Prapporm Langputeh. And then this one is the last one from Philippines, right? This one is third presentation presented by Regie Bautista, MAN.RN from Philippines. And then this one is about the title Shock and Cardiac Arrest Management in COVID-19 Pandemic. And then, so Mr. Regie Bautista, so it's time for you. Time is your. Good morning, Mr. Regie.
Hello, good morning from the Philippines. Mabuhay. We are now in the digital world, and I'm happy so much to see you in our virtual learning. And I want to congratulate our organizers for this event. And this is an exchange of learning around the world. And I hope so that this international webinar we have will be great today. And for our attendees, for our participants, okay, thank you very much for coming us. And I hope you have a lot of learnings today. Today, I will be the one who discuss to you the areas of the pre and intra-hospital basic trauma for the nurses and midwives. Okay, so Ma'am Didin Mulyana, Ma'am Nina told me my topic will be the pre and intra-hospital basic trauma for the nurses and midwives. Okay, so let's start. Did you see my presentation?
Not yet.
Did you see my presentation? Not yet.
Sorry, mister. Your slide is not available for the monitor.
Okay. That's now the reality of the virtual learning. I'm not technological savvy. I'm not good in technology. So please bear with me. Just wait for a minute.
Yes.
I hope you are healthy and okay. We are now in the top list affected case in Asia, and I think Philippines is the top one affected all over Asia. We are so very frightened about this coronavirus, and many people are suffering now because of this disease. Did you see my presentation now?
Yes.
Ma'am Jadine, did you see my presentation?
Yes.
Yes.
Okay, so good morning. So this is now the pre and intra-hospital basic trauma for the nurses and midwives, and I am Regie Bautista. I am the Dean of the College of Nursing here in Systems Plus College Foundation in the Philippines. Okay, so in the area ACs, as you can see in our picture, a lot of troubles, accidents, car accidents, even earthquakes, fires, and even also some problems in terms of trauma. So here, as you can see in our picture, that there is a collapsed airbag, okay, and also collapsed car that is deformed of the during in the road. So in this area is I want to give you a case presentation. I want to give you a logical and critical thinking presentation on how you will do, on how you will give a best care to our patients who are in a suffering of trauma. Okay, now the question here is what are your initial concerns as you arrive on scene? Okay, because here, okay, trauma care is a time sensitive emergency. Pre-hospital and intra-hospital early care are the two necessary interlace, crucial phases in the management of severe traumatic injuries with potential impact on the survival of clients or patients. While the main goals of an effective pre-hospital trauma system are clearly recognized, the relative impact on patients' outcome of different approaches has yet to be established. The diversity among healthcare systems of different countries and the diversity of high-quality evidence make it difficult to reach a consensus on essentially every aspect of pre-hospital trauma management. Once arrived at the selected trauma center within dedicated areas of emergency department, trauma victims should be assessed and treated by a specifically trained trauma team, could be a nurse or okay, I can hear baby crying, and I think she's part of our webinar. And following a classic ABCDE method through stepwise evaluations of the patient and simultaneous emergency damage control maneuvers are performed prior to directing the patient to a dedicated
I'm so sorry.
care plan.
Your time is just 30 minutes.
Yes. Thank you. So the question is, what is trauma? Trauma is a serious injury, okay, that to the body that may be a life-threatening condition to our patient. This is also a response to a deeply distressing or disturbing event. Trauma is not only physical, but also it could be an emotional. Okay, it could be a physical abuse, it could be an emotional abuse. That is there is a disturbing event that overwhelms an individual's ability to cope, or there is a problem in coping mechanism that causes the feeling of helplessness, diminishes their sense of self, and their ability to feel the full range of emotion and experiences. Here also is if you look at in the area of the scene, okay, you have to look at this question: what is the scene size up? Scene size up, it means you have to observe, and there is an observations made and actions taken at a trauma scene before actually approaching the patient. So here you have to initially step. What is your first step here? You have to look at the scenario, look at the scene, okay? So here you have to begin the sizing up the scenes for hazards as you approach it in the vehicle if there is a car accident. Your first decision is to determine the nearest safe place to park the ambulance or the rescue vehicle, of course. And you would like the vehicle as close, okay, to the scene as possible, and yet it must be far enough away for you to be safe while you are performing the scene size up. In some situations, you should not enter the scene until it has been cleared by fire personnel, law enforcement, or it could be an hazmat technicians, or it could be an emergency personnel. Next, here you have to determine if it is safe to approach the patient. The question here is, okay, once you are performing the scene, you have to wash out the windshield survey before leaving your response vehicle. Consider the following. Okay, the crash or the rescue scenes. Okay, is there a danger from fire or toxic substances? Is there a danger of electrocution? Are unstable surfaces or structures present such as ice, water, or slope, or buildings in danger of collapse? Areas with potential for low oxygen levels never be entered until you have the proper protective equipment, okay, or the PPE and breathing apparatus. You should never enter such areas without proper training, safety equipment, and appropriate backup support. Okay, so here also you have to watch out the crime scenes. Danger may exist, okay, even after a crime has been committed, and be alert, okay, for persons fleeing the scene, for persons attempting to conceal themselves or gestures. Do not approach a known crime scene if law enforcement personnel are not present. Okay, so here, wait for the law enforcement not only for your own safety and the safety of the victim, but also to help preserve evidence. Do not approach the scene if you see the law enforcement personnel are in defensive positions or have their weapons drawn. Okay, so you have to consider that, okay, the crime scene. And of course, the bystanders. You and the victims may be in danger from bystanders. Okay, and are these bystanders talking in loud, angry voices? Are people fighting? Are weapons present? Is there an evidence of alcohol or the use of alcohol or use of illegal drugs? Is this a domestic violence scene? You may not be recognized as an emergency care provider, but as a symbol of authority, and thus attack are dangerous. Okay, so here are dangerous animals present? Request law enforcement personnel at any sign of danger from violence. Of course, also, you have to watch out the mass shooting events. Unfortunately, mass shooting events have become too common worldwide. Classic instructions for emergency care providers have been not to enter the scene until the law enforcement has secured it, which could take a long time. Okay, based on the analysis of the number of events, the Hartford Consensus document recommends that emergency medical personnel responders enter the scene with law enforcement protection when an area with victims has been rendered safe, meaning there are no immediate threats in the area in which the emergency medical personnel are operating. Then control and life-threatening hemorrhage in victims found and rapidly evacuate them to a safer area for further assessment and treatment. So another type here, okay, of hazardous space is the blast scene. As you can see and as you heard the news in Lebanon, in Beirut, okay, there is a blast scene there. So explosions usually are associated with industrial accidents, but because the threat of terrorist activity is both common and worldwide, it should be considered when approaching the scene of an explosion. In addition, in some countries, the proliferation of illegal methamphetamine laboratories, shabu, okay, has been associated with an increased incidence of chemical explosions. Whatever the cause of an explosion, if possible, law enforcement personnel, police, along with the bomb technician and a hazmat technician should first evaluate the blast scene to make sure it is safe to enter, okay, and that no chemical, biological, radiological hazards exist. And if possible, park your vehicle outside the blast zone because the area where glass is broken. Okay, if you are not sure of scene safety, call for ambulatory victims to leave the scene by following a designated emergency responder to a safe area for triage and decontamination. Okay, so that's a part of you have to consider the following. Okay, and look out the scene or you are size up the scenario. As you can see in the picture here, okay, there is area of the scene. Then you have to transport the patient, and you have to transport the patient to the facility or to the emergency unit care. Okay, so there is algorithm here, a concept map that the patient is our priority in case of blast, in case of trauma, or in case of an accident. So the question is, what is pre-hospital care? Okay. Pre-hospital trauma care, okay, is a giving medical care to patients beyond the wall of a hospital. Okay, even the patient is in the road, even the patient is in another area, it's not in the hospital. We nurses, we midwives, we take our oath to give our best quality care to our patients. And here is to respond the high demand from policemen or policymakers for guidance on the topic of pre-hospital care. The WHO, the World Health Organizations, developed a pre-hospital trauma care systems wherein it's prepared within a network of experts from all regions. Okay, wherein here is they recommend some areas that covered include the organization of the pre-hospital trauma care system, the capacity of development, the data collection, transportation and communication, and as well as the ethical and legal considerations. So what are the recommendations here? Okay, here is recommendations contained in the publication of the WHO or the World Health Organization that addresses the several different scenarios, such as how to initiate a new formal emergency medical services where none previously existed, alternatives to formal EMS with ambulances when resources are constrained, such as by training of those first responders who are already constitute the de facto hospital, okay, pre-hospital care system in a given area, and how to strengthen the existing system, the basic EMS systems. Okay, so here there is a wide range of activities here. There is a ground ambulance service. There are a lot of EMS personnel or emergency medical system personnel. And take note of this: if you are a nurse, okay, or you're a midwife, and there is an accident, we nurses, we have the right to give our patient the best quality of care. Okay, so here as a nurse and as a midwife, we have our training. We are the first aider, and we are the first responder to these patients. Okay, and what is the aim of the WHO in the pre-hospital care is to reduce the morbidity and mortality in those seriously injured and dangerous ill patients outside the hospital. And did you know in the Philippines, majority of the trauma or accidents here is on motorcycles? Okay, so 30% of people, okay, in the road, okay, in the expressway, having their accidents, and some of them died. Okay, so here is we the nurses or the midwives, we have to give our life-saving care to our patients if it is happened, and we have to stabilize the patient's condition and to maximize the chance of good definitive care. Okay, so what is the immediate and urgent care? The immediate care is to seek medical help. If you are not a nurse, if you are not a health care personnel, okay, you seek medical help. In the scene, you have to transport this patient, okay, to the nearest hospital or to the nearest emergency. So in order to give a special treatment and evaluation, and by doctors and paramedics that are also, okay, have received special training and equipment. Okay, so here, when the unexpected happens, okay, what is the difference between the emergency room and urgent care? And what are the illnesses or diseases that needs an emergency, that needs an immediate medical care? Okay, it's that means that these diseases or these illnesses are life-threatening conditions. So in short, if there is a serious injuries, if there is a bleeding, a massive bleeding, if there is a difficulty of breathing, the airway is our priority, there are emergency. If it's just only an allergy reaction, if there is a fracture, if there is a cat or mild fever, it is just an urgent care. So in short, but take note, when in doubt, you have to call the nearest hospital number or you have to call the personnel. Okay, so here and what is triage? Okay, in hospital care, okay, and also in assessing a patient, you have to use the triage. Okay, so the triage is the process, okay, of collecting pertinent information about patients who are seeking medical care and initiating a decision-making procedure that uses a valid and reliable triage equity designation system. This triage also is the sorting. It is sorting and allocating of treatment and to our patients, especially battle and disaster victims, according a system of priorities designed to maximize the number of survivors. The term triage comes from the French word, it means sort. In the hospital, in the emergency department setting, it is the process by which the patients are assessed and prioritized based on the type and urgency of their conditions. If it is a massive bleeding, if it is a stroke symptoms, and the patient here needs an emergency care. But just if there's only a mild fever, it's just only an urgent care. Coronavirus is an emergency care because here the coronavirus, okay, affects the lungs and affects the whole organ system of the patient. So here it needs an emergent care. Okay, so we basically determine here in triage, are they sick or are they not sick, and how quickly do they need to be seen. The initial assessment here ensures critically ill and injured people receive medical attention before those with non-urgent issues, and it supports the best use of hospital space and resources. Okay, now, why do some people have to wait so much longer than others? Okay, the triage nurse listens to the patient's story, of course, the assessment first. They have to check the vital signs and order necessary tests such as blood work. The doctor here ordered some blood works, the ECG or X-ray, and the doctor here and the nurse will also assess if it is need an emergent care. So as you can see in our presentation, there is a color coding in triage. The red, it means emergency care. So what is the patient 1, patient 2, patient 3, patient 4? And as you can see in the bottom area is the patient 5 is considered as dead. If it's dead on arrival, the color of the triage is black. But if it is a need an emergent care, that patients who have a life-threatening injuries and the patients here has a good chance of recovery, of surviving, that color's red. Okay, so if the indicates the treatment may be delayed for a limited use or maybe a limited period of time, it will be yellow. Okay, so it is just only an urgent, it's yellow. Okay, if it's green, it's delayed. If it's blue, it's expectant, and the black is dead on arrival. Okay, so as you can see in our presentation here. So if the patient here doesn't require an ICU, an intensive care unit care, okay, here is just only green. So you can delay it. But if the patients here who have an injuries requiring extensive treatment that exceeds the medical resources available in the situation, consider is as blue, as expectant. So here, if the patient has who are in cardiac arrest and you need you give a resuscitation, but your efforts are not good to be provided, that considered as black. Okay, so here if you're looking for the area of the assessment, you have to check the primary survey. The primary survey is a rapid assessment and treatment of life-threatening injuries. Primary survey is a brief exam to find immediately life-threatening conditions, and it is made up of the scene size up, initial assessment, and either the rapid trauma survey or the focus exam. Okay, as you can see here, okay, there is an ABCDE assessment. The A, it means airway. The B is breathing. The C is circulation. The D is disability. And E is exposure. Okay. So here, okay, you have to wash out the airway. Okay. Here is the airway pattern. Is it, can the patient talk? Okay. Is the patient here snoring? Is there an obstruction of airway? Is there a foreign body in the mouth? So if the patients here the airway is not patent, you have to chin, you have to lift the chin, you have to lift the head, and you have to suction or give an oropharyngeal airway. But take note of this, airway is our main priority. The B is a clear airway. Does it mean the patient is breathing adequately? So here is required to provide an adequate tissue oxygenation. So is the patient here, as you can see in the initial assessment, there is a cyanosis, there is a bluish discoloration of the skin, there is a use of the accessory muscles. Okay, there is a problem in the depth and the rating of the breathing. So there are also breath sounds, as you can hear in auscultation or in the stethoscope. So you have to watch out the breathing. So you should, what will you do? What will you here do? What will be your assessment? What will be your management here? You have to position the patient, okay, in a high Fowler's or in a semi-Fowler position. You have to decompress of the pneumothorax, and you have to look at the inhalations. And in the circulation is you are assessing the skin color. Okay, the skin, is it cool, is it warm, is it dry? And in circulation here also you are checking the capillary fill, the blood pressure. Okay, so what will be your action here? If the patient is bleeding and there's a problem now in the circulation, you have to stop the bleeding. You have to press. Okay, you have to give also IV fluids or IV fluids. Okay, and as you can see also here in the disability, letter D is you are looking the GCS or the Glasgow Coma Scale. The Glasgow Coma Scale is a tool in order to assess if the patient is manifesting a severe stroke, and you have to watch out the recovery. And letter E is exposure. Okay, the exposure is the head-to-toe assessment. Here, remember to document all the assessment, the treatment and responses to treatment in the patient's clinic, okay, clinical notes, or in the cardex. Okay, so here you have to watch out if there are trauma, if there are bruises, fractures, lesions, infections, and even also rashes or petechiae. Okay, so you have to stabilize the patient. What will be action here? You have to stabilize the fraction. You have to prevent hypothermia and hyperthermia. So here also, that's a part of the primary survey. And this secondary survey, you are looking here the complete physical examination, and you are assessing the patient and re-evaluating, okay, the patient's status. Okay, so what are the golden principles of the pre-hospital trauma care? So your main priority here is your safety. Of course, you have to determine the need for additional equipment or personnel. You have to also look at here the priority of the patient and also the crew or the staff safety. You have to ensure that the safety of the crew and the patient. You have to anticipate the risk and ensure safety of all emergency responders. In violent crime, law enforcement personnel must partner with the healthcare, with the nurses, with the midwives. The PPE, the personal protective equipment against body fluids such as HIV or hepatitis B. The nurse must and the midwives must have the personal protective equipment. Here also you have to assess the scene, scene situation to determine the need for additional resources. Okay, and you have to recognize the kinematics that produce the injuries, and you have to use the primary assessment to identify the life-threatening conditions. You have to focus on the A, B, C, D, E. Okay, so what is the A, B, C, D, E? The A is airway, B is breathing, C is circulation, D disability, and E is the exposure to environment. You have to input from several senses. Okay, and during transport, the primary assessment here should be reassessed at reasonable intervals. You have to provide appropriate airway management while maintaining cervical spine stabilization is indicated. You have to support ventilation. You have also to obtain a sample history of a complete of secondary assessment and consider it medical transportation. And that is the part of the pre-hospital. And now we are now in the intra-hospital emergency care, wherein the patient now is in the hospital, is in the emergency room. Here is we are looking for the chain of survival. So here in the pre-hospital, you give an early first aid to prevent immediate deterioration. And after that, you have to secure the vital functions. You have to get the vital signs. You have to give an early basic life support or advanced life support. And then you have to limit the injury, so there is an early advanced therapy if it needs an operation, and to restore the quality of life there is a rehabilitation. So this is now the survival, the chain of survival. So the first aid, the basic life support, you have to lessen the damage control. You have to lessen the damage, and you have to look at here the resuscitation, and the last is the rehabilitation. So here, the chain of trauma survival is a concept that originated in the area of out of hospital cardiac arrest and was adapted to the treatment of trauma. In out of hospital cardiac arrest research into bystander, first aid has resulted in improved outcome, where areas in trauma research, the first link of chain of survival is almost ignored. Here, again, okay, this is a part of the intra-hospital trauma care. You have to receive the patient in the hospital. You have to triage it. It is an emergent. If it is an urgent, is it delayed? Is it dead on arrival or black in color? And you have to give a resuscitation if the patient here needs a recovery and has a good vital signs, and you have to stabilize the patient. You have to register the patient, okay, in your data, because here you have to document. If it is not done, okay, if it is not documented, it is not done. Okay, so also here you have to investigate, you have to give assessment, you have to ask your patient, you have to look, feel, and listen. That these are the three areas of senses as the assessment entails to our profession. And of course, the best definitive care is to give treatment and evaluation. And you have to dispose of any infections or any body fluids, okay, comes from our patient to prevent reinfection. Okay, so the conclusion here is if there are bystanders there, okay, you have to simple like this. Okay, if there are bystanders, you have to assess the scene first, and if the bystanders is not in healthcare and has no ability to have give first aid, please seek medical help. And you have to give an emergency service dispatch. You have to transport the patient to give the best interventions of care, and you have to give an early assessment and evaluation to your patients. Okay, so terima kasih, and may the good Allah bless us all. So do you have any questions?
Okay, thank you so much. Give applause for Mr. Regie. Any question? Just one question. Okay, Mr. I think no question. Okay, thank you so much, Mr. Regie, for your explanation for the subject. Give applause for Mr. Regie. Okay, thank you for your time, Mr. Regie. See you later.
Thank you very much, and may the good Allah bless us all. And I hope you are okay and healthy to this type of pandemic. And we have to unified prayer to those who are sick, because nurses and midwives, this year is our year. The year of 2020 is the year of the nurses and midwives. And congratulations to all of us. Mabuhay from the Philippines.
Okay, thank you so much, Miss. Dari Mbak Safira Nur Adilah dan Mbak Ana Noviana Wiwatri. ya tentang infection prevention of COVID-19 during pregnancy. Kepada Mbak Safira, terlebih dahulu kami persilahkan.
Okay.